It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Have a lot of great stuff coming up. We have the June board review course in Manhattan, and a bunch of you guys are staying after that to do the ultrasound course with me on Sunday. If you're interested in doing both or one or the other, just go to painexam.com and you could sign up. Also have an ultrasound course in July and August coming up, as well as an ultrasound course in Puerto Rico in September and the regenerative medicine course in November. So just go to painexam.com/events and you'll see what I'm talking about. American Society for Pain and Neuroscience, ASPEN, is coming up in July. I'm going to be faculty and teaching ultrasound there on Sunday, so hope to see you there. And then, of course, NICEP and all the other fall and winter conferences. So there's a lot going on. If you guys are studying for your boards, go to painexam.com. PM&R docs out there, I'm looking to expand the PM&R board review on my NRAP website. So if you're interested in writing questions, please reach out to me. And you could get CME credits as well as free access to the website. So that being said, I wanted to discuss today prolotherapy, which has been around for a long, long time, and there is evidence suggesting it works, but many people really are not familiar with it, especially people coming from the anesthesia world. I feel like a lot of the PM&R people are more familiar with the concept, and it's probably one of the most regenerative medicine procedures we've had before the PRP had existed. And what prolotherapy really is, it's basically stimulating the healing of loosened ligaments and tendons. It's cost-effective, it's safe, and you're treating various musculoskeletal types of pain with this. And I'm looking at a study where it's actually a systematic review and meta-analysis where they looked at 10 studies involving 750 participants. The pain scores were taken from 6 months to 1 year after dextrose prolotherapy, and they were significantly reduced compared to saline injection, as well as compared to exercise, which was surprising. Prolotherapy yielded similar results to PRP or steroid injection, and it showed no significant difference in pain score. Their conclusion was that dextrose prolotherapy was more effective in the treatment of chronic pain compared to saline injection or exercise. Its effect was comparable to PRP and steroid. I'm just reading straight from the abstract. And they're saying, of course, more adequately powered, homogeneous, and long-term trials are needed to better elucidate the efficacy of prolotherapy. So let's delve into it, right? So they're considering chronic pain, as most of us, more than 3 months of pain beyond the normal healing period. The musculoskeletal disorders are quite prevalent, and physical therapy, pharmacotherapy treatment, injection treatments are utilized. And corticosteroids are probably the most common regimen for musculoskeletal disorders because they provide quick results, short-term improvement, but they can aggravate cartilage damage, thus increase the risk of tissue atrophy. Many physicians, like myself, have become more interested in alternatives such as PRP or prolotherapy. And prolotherapy is non-surgical regenerative injection technique that administers a small amount of the irritant solution to the degenerated tendon insertion, or the entheses, I'm not sure if I'm saying that right, to the joints, ligaments, adjacent joint spaces over a series of several treatments. The mechanism of action behind prolotherapy is not completely understood, but the theory is the injection causes a healing process to occur by stimulating the body's natural inflammatory cascade, and it's triggering the release of growth factors, collagen deposition. And to date, many studies do support the benefits of prolotherapy, and It's treated chronic pain for a variety of conditions, and here they're just analyzing it. So I'm not going to get into the details as to how they analyze it. If you want, you can read the article and nerd out on that. I'm just trying to give you an overview as to what these guys did. And they retrieved 680 articles. They sifted through them. They excluded 567. And the primary selection was on 131, but then they excluded 66 of those patients. Another 27 were just abstracts, so they excluded those. And of them, 38 full-text articles, of which 28 were excluded. So basically, they took a lot of data and they really fine-tuned it. Now, anecdotally, I know a pain physician who is doing a lot of spine prolotherapy, and he's saying it's working amazingly. And to be honest, I believe him. Think about it, right? Nobody talks about the ligaments of the spine. I mean, of course, we all talk about ligamentum flavum, right? All the anesthesiologists and interventional pain docs do, because that's what we feel when we do the epidural. It has a very characteristic feel. But we have so many ignored ligaments. The intertransverse ligament, which is the ligament between transverse processes. Then you have of course, the supraspinous ligament, which those of you who are doing your spacer devices either cut through or avoid by going through it, depending on which device you're using. There's also the Ilolumbar ligament, and these ligaments. I mean, wow, Ilolumbar ligament is really right over that L5/S1 region or L4/S1 region, where everybody's pointing to, right? When your patients come to you and they're pointing to that area medial to the PSIS or a little above, a little below. Well, there's a lot of other things there, right? You have your exiting foramen, you have your facet joints. So it's kind of crazy how we do all these procedures and we talk about facet, disc, muscle, but these ligaments are for the most part ignored. And I'm wondering why that is. And there's probably a few reasons. It could be just because maybe the ligaments are not so obvious on X-ray, or maybe not so obvious on ultrasound, and maybe just you just assume it's a regular trigger point, and when you're doing your trigger points, you're probably anesthetizing or you're injecting the ligament as well as the muscle as you go through it. But I hope to one day map out these ligaments with an ultrasound and present them for you. But isn't it kind of crazy how there are these structures in the spine that actually could be causing pain that a lot of us just ignore, and or don't. It's not that we ignore it; we just assume it's something else, right? So this is something maybe you consider in those patients who really is not responding to your classic therapies, or maybe you should use this as a first-line therapy. Now, as an FYI, doing some literature searches on the Ilolumbar ligament, the PTs, the physical therapists, are talking about this all the time. I did find a bunch of articles, though, on my search where they do talk about this, and I don't see too much from the interventional pain world, except for something from 2011 by Dr. Harman Alexiev in Pain Physician, where they're talking about the sonoanatomy and injection technique of the iliolumbar ligament. And they're mentioning how the ligament obviously could be part of the axial lower back pain syndrome, and it's actually a very common source. And the ligament runs between the transverse process of L5 and the medial deep iliac crest. It has a biomechanical role in anchoring the spine to the pelvic ring and stabilizing the SI joint. The iliolumbar syndrome is a painful condition caused by pathology of this ligament. It occurs in people who are lifting too heavy loads while rotating manually, such as golf players, manual workers, and it's believed to be a ligament strain, and there's tenderness on palpation of the posterior medial aspect of the iliac crest. Pain is provoked by lateral bending to the opposite side. One has to consider, of course, other sources of pain, such as the quadratus lumborum, the rectus spinae muscle, the facet joints, the SI joint. And I hate to say it, but most of us will consider these other pain generators before thinking of the iliolumbar ligament. However, it's important to consider this. It's a difficult diagnosis to make without image-guided injection. Ultrasound does offer the advantage in the setting, and These docs have some nice pictures in this. I'll have a link to the show note. So they basically wanted to map it out via the ultrasound, and they basically go into the positioning of the ultrasound, and they have some nicely labeled images showing the transverse process with the Ilolumbar ligament and their target point on the ultrasound, which I'm looking at these pictures, and it's something I haven't typically targeted in my practice, but they're making sense to me. So good job. And basically they detail how they took care of a patient, and they injected the patient with some local anesthetic. And this was just a case report, but this one patient did great, and they outline it, and they do say the weakness was, or the limitation was, that they could not confirm local anesthetic spread with MRI. Of course, this is an ultrasound image, which actually you could see the local spread around your target. So, but I guess the MRI would be a lot more specific and as to where you are. Now, just doing a little digging here, just finding out, different protocols for prolotherapy. I found a study regarding epicondylitis, just of mention, and they're comparing low doses, about 5%, 1%, 10%, with higher doses of dextrose, 15%, 20%, and 25%. They're suggesting the low dose may have less cellular damage associated with it, and they're saying that the study effects are similar. So it's something to keep in mind if you're doing these procedures. And lastly, I just want to touch on protocols. There are different protocols. I found one study doing 1 shot weekly, and in another study, they're looking at week 4, week 8, week 16. So there's all sorts of different protocols, and I'm sure everybody has their own little tricks of the trade when it comes to this sort of thing, because it's not like a set type of black and white procedure or protocol. And this is not reimbursed by insurances, at least not to my knowledge. So what prompted my delve into prolotherapy, which I'm going to be performing, and I haven't really done much of it, is that I have a patient suffering with chronic greater-trochanteric bursitis and tendinitis of the tendons that insert there, gluteus medius, minimus. And so she benefits from steroid shots, but they don't last long enough, and she wants something longer lasting. And I offered her PRP, which she wants to take. She's concerned that it will reactivate her SLE, which is in remission, which I am not aware of any risk to that. And I spoke to some other pain physicians, some really well-known people in the field of regenerative medicine and interventional pain, and none of them could tell me of any contraindication for this patient to platelet-rich plasma. However, she's still nervous about it, and she was much more comfortable with the idea of prolotherapy. So I am planning on doing prolotherapy, and I'll let you know how that goes. Anyway, that being said, I hope this was helpful to you guys. I hope it opened your eyes to a few things, because a lot of us from the anesthesia world are not really exposed to prolotherapy. Believe it or not, although I don't do a lot of it yet, I'm saying yet because of I'm planning on implementing it into my practice, because it appears to be safe and effective for the patients. I hope to have more information available to you soon. If you have any comments, I know a lot of you are probably doing this a lot. Some of you maybe only do prolotherapy, so you could probably teach more about it than I could. But I'm open to your thoughts, criticisms, ideas, etc. Anyway, thanks for listening to the podcast. Please take a minute to like the podcast, give it a great review. Also, remember, we have the board review pain exam. NRAP Academy, nrappain.org has the anesthesia and PM&R board review. And then, of course, in-person courses. Come stop by a course either in New York, or the Middle East, Caribbean, wherever I can find a place to do a course. I'd love to see you there and hang out, talk pain management, regional anesthesia, regenerative medicine, and much more. Have a great day and good luck.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced
produced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.